a couple of practice pearls. We're going to talk about recruitment maneuvers with the 3100B oscillator. Anytime that you have to remove a patient from the oscillator, their lungs de-recruit and they collapse very quickly. So in order to re-expand the lung, a lot of times what you'll see people do is doing a recruitment maneuver. Now there's different maneuvers that we do for different patient situations, but typically what you'll see is we'll have the oscillator with the piston off like it is right now, and we'll take the mean airway pressure up to about 40 centimeters of water pressure, and we'll hold there for 40 seconds. Now clearly if the patient becomes compromised, you're going to have to start ventilation. You're not going to let them get to a heart rate of 30 before you start the ventilator. But you know, you want to get those lungs open as much as you can, as quickly as you can. If you're already on a very, very high mean airway pressure, say you're already on 35, 36 of mean, then try to get to 10 above that if you can for a recruitment maneuver. And I'm not saying that you'll be able to get that high before you get into some situations with cardio compromise, but if the patient tolerates it, it's best to recruit this lung and get the lungs open back up. Another thing that you want to remember as far as a practice pearl is concerned is when you're suctioning the patient, you want to stop the piston. So if a person is on the oscillator, the piston's going, and you need to suction your patient, before you advance your catheter, stop your piston. Now you'll notice when the piston stops, it's still maintaining mean airway pressure. It's just not oscillating at that point. At that point, it's safe to advance your catheter, suction, do your lavage, and so forth and so on, because you're not breaking the circuit. Then you can come back after you've lavaged and suction and start your piston again. Another thing that Scott wanted me to talk about is the use of bronchoscopy with 3100B ring oscillator. It is possible to do it. We use a bow tie in line, and it would go, of course, at the patient connect, and you can actually go down, and you want to hyperoxygenate as much as you can, and again stop the piston as you introduce the bronchoscope, and continue to observe the vital signs and so forth. When they start to show signs of decompensation, you're going to have to come out with your bronchoscope and again start the piston and start ventilation again. When the patient stabilizes, you can go back in. We do have some situations that require bronchoscopes and bronchoscopy, because a lot of people that we use this on will be on for a fairly long period of time, and the secretions can become inspissated. If that happens, then you're either going to do a bronchoscopy, or you're going to have to lavage, suction them. Another thing to remember as far as pearls of suctioning is concerned is if you have to break the circuit, talk to the nursing staff, make sure that you cluster your care around these circuit breaks, so that if the person needs to have their head turned, or if they need to be prone, or something like this is the time to do that sort of thing. So we cluster care around those infrequent circuit breaks if we can, re-recruit, suction them out, get them going back on, and hopefully be able to transition back to conventional ventilation within a reasonable amount of time, whatever that may be for the patient and for our blood gases and for our chest x-rays.